Hello, everyone, and welcome to Heads Up, the weekly webcast and podcast of the National Headache Foundation. I'm Dr. Lindsay Weitzel, migraine strategist, founder of the Facebook group Migraine Nation and chronic daily migraine survivor. I am lucky enough to be here today with Dr. Jan Brandis, MD. Dr. Brandis is the founder of the Nashville Neuroscience Group and an assistant clinical professor in the Department of Neurology at Vanderbilt University School of Medicine. She also, happens to be an investigator for multiple migraine clinical trials. Hi, Dr. Brandis. How are you doing today?
Hi. Thank you for having me.
Thank you so much for being here. So we have an awesome topic today. We have had Dr. Brandis on before talking about issues relevant to women and migraine, and she does an amazing job. And so we are going to talk today about perimenopause, menopause, and hormone replacement therapy and issues related to this. And Dr. Brandis is going to tell us all sorts of things that we need to know. So I think there's a lot of misconception out there when it comes to perimenopause and menopause and migraine. I think so many women assume that they're going to hit that stage of life and migraine is going to get better for them. And then they get there and sadly they're shocked to find out that that just isn't true. So let's get some of the facts on this stage of life. First, let's define the difference between perimenopause and menopause.
Well, perimenopause really refers to it's really a stage of life, and it refers to the period of time, say the last 5 to 7 to 8 years before the cessation of the menstrual cycles. Mm-hmm. Menopause itself really begins 1 year after the last menstrual cycle. So what we often call menopause is really perimenopause. When we talk about menopausal symptoms of hot flashes and worsened migraine and night sweats, that's usually actually occurring during perimenopause. After menopause, the ovarian function really ceases and estradiol levels fall, and they're low and really stable after that point, which is why some women, if they have a strong estrogen driver for their migraine, have their migraine get better. But estrogen's not the only driver for migraine in many women, and those are the women who, unfortunately, have often been led to believe they'll be better at migraine, at menopause, in terms of their migraine, but they actually are not.
Right. So what usually happens to women with migraine as they approach menopause? I think you've mostly answered this question, but do you know if most of us, and look at me, I'm going, am I going to get better or worse?
Well, it's so fascinating. I think what you can see, and it's one of the places where I love to take the history from someone, if you have someone who suggests that estrogen plays a big role in their migraine, so the person with menstrual migraine may well do better after menopause. Mm-hmm. A person who responds to either high and stable levels of estrogen, like the person who's much better during pregnancy, mm-hmm. or the person who does much better when they are on a lower estradiol dose, if they are receiving that during perimenopause. Those individuals may be the ones that do better when they get to actual menopause. But the problem is during perimenopause, which again can go on for years, the average age for entry is about 47. Mm-hmm. So for many women in that time frame, their estrogen levels are actually higher. And so that means when they fall, they have a longer way to fall. Mm-hmm. And menstrual cycles can be more irregular. And so women may have actually higher frequencies of migraine in their late perimenopausal years, which just makes everything worse because they have all these perimenopausal symptoms and they have worsened migraine and often longer duration migraine during those years.
Okay. So if women take HRT or hormone replacement therapy for symptoms of menopause, does this usually improve their migraine symptoms or does it make it worse?
Well, about 50% of the time, they say the statistics usually show that about 45% of women with migraine do better on HRT, about 46% do worse on HRT, and about 5% don't have it affect their migraine very much. Okay. So it's really, I think, the luck of the draw. What I often tell patients is hormone replacement can do anything to your migraine. We have to, if we think it's an appropriate choice for you, then we have to watch very carefully. And I think one of the strategies that's used in the United States, not infrequently, is that if a woman is on oral contraceptive pills, and maybe she's doing that for birth control, maybe she's doing it for control of endometriosis, maybe she's doing it for ovarian cystic disease, so any number of reasons, maybe she's using it for dysmenorrhea, so many things other than just contraception. It may be that as she moves further into perimenopause, her placebo weight will be dropped. And then as she moves into late perimenopause, the transition will simply be made to hormone replacement therapy. I think the thing that we've learned is that that really needs to be a transdermal therapy, so that it's not
meaning on the skin, meaning you're absorbing, so right, instead of taking it.
That's exactly right. And the Women's Health Initiative, which I think terrified so many women and their physicians about oral estrogen, for example, and Premarin, the drug that was looked at in that study, showed higher risk for stroke, non-fatal stroke. But when we think about women who are moving from, say, late perimenopause into menopause, one of the big issues is bone protection. The first 5 years of menopause are the major years of bone loss. And so that's a time when estradiol, if you can get a stably delivered dose, you may be offering bone protection, you may be helping migraine, and you may also be helping with the unpleasant symptoms of perimenopause. And so I think the guidelines now suggest that if you think that's an appropriate choice and you're using a transdermal or through the skin delivery system, at the end of, say, 3 to 5 years, you can reassess and see if that continues to be the right thing for an individual.
I just really quick want to clarify something you said. You said dropping the placebo week, and you were talking about women who were on oral contraceptives, right?
Yes.
And
during their perimenopause.
During perimenopause. Can you just go ahead and explain that in case people don't know what dropping the placebo week meant?
Yes, and thank you, because that sounds confusing. So it would mean eliminating. So it would mean, say, the person that has been doing very well in terms of menstrual cycling, and they have a 5-day period where they're on placebo or the sugar pill, as some people like to think of it. And then maybe as they move further into perimenopause, their cycles become more erratic. They begin to have more menstrual migraine. They have more breakthrough bleeding, and every time they break through bleed, that triggers an event. Sometimes gynecologists will recommend that the patient have no placebo days. So they will simply take an active pill, an oral contraceptive pill, every day to try to stabilize the hormonal levels. And again, as someone nears menopause, so around that sort of magic age of 50, then often, if it's felt appropriate, that person might transition to true hormone replacement, and that would be a transdermal form. If someone has a uterus, they need to also be on progesterone. And again, you can have their formulations that can be used for that as well.
Okay. So this is an important question, I think, because not only do I hear this question a lot, but I see countless posts online from women asking if they should get a hysterectomy to improve their migraine symptoms. Now, my understanding of the literature and my experience in people I've seen is that maybe this could make migraine symptoms worse. Can you please comment on this?
Yes, I would say sort of unequivocally, there is no indication for hysterectomy or oophorectomy, so having a uterus or ovaries removed to help migraine. So that really should never be a recommendation. Now, of course, many women have to have hysterectomy and oophorectomy for other reasons, and it can make migraine worse. And then in those situations, again, we're often really sort of scrambling to try to find appropriate therapy, prevention, and acute therapy, and to try to figure out whether they're candidates for hormone replacement. And often, of course, they're not. So I would say no one should ever have hysterectomy or oophorectomy or both for migraine, for treatment of migraine.
And do we know why it makes it worse?
Well, there are a number of theories about it. One of the challenges is that you don't have the ability to replace the hormonal milieu that would be sort of the natural evolution that a woman would go through during perimenopause and menopause. So that's part of that. And then sometimes it's related to the other tissues also produce estrogen. So there are other endogenous sources of estrogen, which may play a role in fluctuation. So there are a lot of different things that come into play. And, you know, one of the things that's been of more concern, there's the suggestion from some groups that if you have oophorectomy, or even if you've had one or both ovaries removed, that you have an increased risk for dementia. So there are a lot of implications about what happens in that setting. And again, some of the older literature didn't look specifically at who had hysterectomy, who had their ovaries left, were they on hormone replacement or not. So they're not great studies looking at that, but there certainly is no evidence to suggest that either removing ovaries or a uterus will ever help migraine.
Okay. If a woman's migraine disorder does become worse as they are in or they approach perimenopause, what specifically do you do? How do you approach that patient?
Well, I think one of the initial things we want to do is make sure that if they're having attacks that we clearly associate with hormonal fluctuation, is that we work with the gynecologist to try to see, if appropriate, can we come up with a strategy that will stabilize estradiol levels. And that may be the pill, depending on where an oral contraceptive pill, that may be an estrogen patch. Those may be part of the strategies. Sometimes we do just conventional therapies, and say a woman who's had breast cancer who cannot be on any form of hormonal therapy, then we just have to be really aggressive about prevention, and that may be one or two or more preventive strategies with very aggressive acute therapies. So it really depends on what a woman can be offered based on her history. I would say also the other place that's really important is we certainly need to make sure that no one smokes in that if they're going to be offered therapy. And that's a time when many women may have never had an issue with it, but they may, if they go on hormone replacement therapy, they may never have been on oral contraceptive therapy. And if they have an undiagnosed clotting factor, they can have a deep vein thrombosis, or they can have some other factor that will really change their ability to continue to be on hormone therapy. So it's really important to take family history, make sure there's not some gene lurking in the background that puts them at higher risk, make sure they're not smoking, and also make sure if they're using an estradiol formulation that it's one that goes through skin.
Okay. So we went over formulation. It's best to use transdermal, one that goes through skin. Is there anything else you'd like to add to our discussion on menopause, perimenopause, and migraine?
I would just say that, again, keeping a diary is very important for looking at these patterns, keeping track of how many days someone has breakthrough bleeding or regular menstrual flow, charting their symptoms. If they're having a lot of fatigue and word finding difficulty and night sweats, sometimes the only thing that really tags to perimenopause is worsened migraine. So sometimes people are actually in perimenopause and having more estrogen fluctuation, and that's why they're having more estrogen, and they're not really having other so-called perimenopausal symptoms. So not being afraid to really discuss where they are in their reproductive lifespan or in their hormonal milestones is important, because if they can have that addressed, they really may be able to have a remarkable benefit and feel better overall and protect their bones and not have to have migraine. And then there are the lucky women who have this improvement, and some of them really do better off hormone replacement therapy. So again, it's really having somebody that can have that discussion with you and continue to look for strategies that are tailored to what you and your family history and then what your actual migraine needs are.
Okay. Well, thank you so much for being on the podcast today. And thank you everyone for watching Heads Up, and please join us again next week. Have a great week, everyone.